Hello everyone. Today we are going to discuss about anticoagulants, continuing with the topic of antiplatelets, anticoagulants, and fibrinolytics. We have already discussed about the antiplatelets. Now I'm going to discuss about the anticoagulants. And anticoagulants are divided into two groups. One is the parenteral anticoagulants, and the other one is the oral anticoagulants. Heparin is the prototype example for parenteral anticoagulants, and warfarin is prototype example for oral anticoagulant. So again, this topic is slightly lengthy topic, so I have divided it into two lectures. In this lecture, we are going to discuss about the parenteral anticoagulant. So first, we'll be discussing about the heparin, and then we'll be discussing about some of the direct thrombin inhibitors. I'll start with heparin. So heparin is a sulfated polysaccharide. So it's a polysaccharide molecule, and the polymer is consisting of alternating D-glucuronic acid, D-glucuronic acid, and N-acetyl glucosamine. So it's a polysaccharide consisting of these alternating polysaccharide molecules. It is usually it is isolated from mammalian tissue rich in mast cells. But the commercial heparin comes from the portion intestinal mucosa. Okay, so these are some of the one-liners that you have to remember. Now we'll go to understand the mechanism of action. Okay, so if you see here, this is a unfractionated heparin. This is a unfractionated heparin molecule, and you can see there is a pentasaccharide sequence. This is a pentasaccharide sequence. Now this pentasaccharide sequence is very important for the function of the unfractionated heparin. Now this heparin, what is the function of heparin? Now heparin will bind to antithrombin. So this is the antithrombin molecule, and the function of antithrombin molecule is inhibiting the thrombin and the factor 10 along with the heparin. When it binds to heparin, it will inhibit the factor 10, and once the thrombin is brought closer to this antithrombin, then it can also inhibit the thrombin. Okay, so this is the antithrombin molecule. Once this heparin, unfractionated heparin, once it is bind to the antithrombin, they will form something like this. Now here, this structure can bind factor 10A. This structure can bind factor 10A. Now factor 10A is inhibited here. Factor 10A is inhibited. For inhibiting this factor 10A, this unfractionated heparin needs only this pentasaccharide molecule. Okay. So to inhibit the factor 10A, unfractionated heparin needs only this pentasaccharide molecule. It doesn't need this extra length of polysaccharide molecule is not required to inhibit the factor 10A. Then what is the function of this extra length of polysaccharide? Now this extra length, they will form a loop. They will form a loop like this, so that they can bring the thrombin molecule into the vicinity of the antithrombin. Okay, I hope it is clear. So the pentasaccharide molecule is enough to inhibit the factor 10A, but to inhibit factor 2, that is thrombin, the rest of the polysaccharide portion of the unfractionated heparin will form a loop, and that will bring the thrombin molecule in the vicinity of antithrombin, and now thrombin is also inhibited. So factor 10A and factor 2, that is thrombin, both are inhibited by unfractionated heparin. Okay, and usually this unfractionated heparin is around, it usually has this 18 polysaccharide length, 18 polysaccharides, and this 18 polysaccharide is enough to inhibit both factor 10A and thrombin or factor 2. Okay. So this 18 polysaccharide molecule is enough to cause inhibition of both factor 10A and factor 2, and this 18 polysaccharide molecule is present in unfractionated heparin. Okay. Usually the molecular weight is around 5,400 Dalton for this 18 polysaccharide, but the commercially available unfractionated heparin, the molecular weight is around 18,000 Dalton. Okay. This is what is available, but if you take the active molecule from that unfractionated heparin, it is only this 18 polysaccharide length molecule, and this has a molecular weight of only 5,400 Dalton. Okay. If you compare this with low molecular weight heparin and the Fondaparinux, see the low molecular weight heparin, this is slightly smaller than the classical unfractionated heparin, and this shorter version, that is the low molecular weight heparin, it will have 17 polysaccharides. 17 polysaccharides. Now the important thing is this low molecular weight heparin will also have the pentasaccharide molecule which was present in the unfractionated heparin. So the pentasaccharide sequence is universal. It will be there in unfractionated heparin, in low molecular weight heparin, and also in the Fondaparinux. So low molecular weight heparin will also inhibit the factor 10A. Will also inhibit the factor 10A with same efficacy, but it will have a reduced efficacy in inhibiting the factor 2 or thrombin, because it is unable to form the loop. It is unable to form the loop for thrombin. It is unable to form the loop for thrombin because it has a shorter length. Okay, so that's why it will inhibit the factor 2, but at a very low efficiency. So factor 10A to factor 2, anti-factor 10A to anti-factor 2A activities around 2:1 to 4:1. In case of unfractionated heparin, the anti-factor 10A to anti-factor 2 activity is around 1:1. But here in case of low molecular weight heparin, the anti-factor 10A activity is more and anti-factor 2 activity is less. In case of Fondaparinux, so this is Fondaparinux. Anyway, we'll be studying in detail about all of them. This is just an overview. Fondaparinux will only have this pentasaccharide sequence which will cause it to inhibit only the factor 10A. So it has only anti-factor 10A activity, only anti-factor 10A activity, and it doesn't have activity on the factor 2. So this is the mechanism of action. Along with that, this heparin can also cause increase in tissue factor pathway inhibitor. This is also another mechanism of action of heparin in causing anticoagulation. This is about the mechanism of action of this heparins. Now coming to the pharmacology, heparin is administered either sub-Q. Now we are discussing only about the unfractionated heparin. After this, we will be seeing about the low molecular weight heparin and then the Fondaparinux. So unfractionated heparin, either it can be given sub-Q or IV. But remember, if you are giving for therapeutic purpose, it is always better to give IV. Sub-Q, if you are giving for prophylactic purpose. If you want to give sub-Q at a therapeutic dose, the dose will be very high. The dose has to be very high. Okay. So if you want to give sub-Q for therapeutic purpose, give very high dose, and it is given as a continuous IV infusion, because the half-life is very low. We'll be discussing about that in the next slide. The half-life is low, and that's why it has to be given a continuous IV infusion for to have a therapeutic effect. But if you want to give prophylaxis, you can give subcutaneous, and if you want to give subcutaneous dose for therapeutic purpose, you have to give a very high dose. Now, what happens inside the circulation once you administer unfractionated heparin? What will happen inside the circulation? Now, inside the circulation, this unfractionated heparin, they will bind to endothelium and they will bind to plasma proteins. Antithrombin is a plasma protein. Usually, heparin for the action of for anticoagulant action, unfractionated heparin has to bind to antithrombin. Okay, but along with antithrombin, it will also bind to some of the other plasma proteins that will affect its function. Okay, so that's why this action of unfractionated heparin is very it's unpredictable. Okay, we'll be discussing more about it its action is very much unpredictable because it will bind to endothelium, it will bind to macrophages, it will bind to various plasma proteins, and this level of plasma proteins will vary in different people and different patients. So it's highly unpredictable. That's why uh, in all situations, almost in all situations, we always prefer using low molecular weight heparin rather than unfractionated heparin. Anyway, but you have to understand the pharmacology before going on to read about the low molecular weight heparin. Non-fractionated heparin, they will bind to endothelium, and they will also bind to the plasma proteins. So because they bind to endothelium, they will show a dose-dependent clearance. They will show dose-dependent clearance. What do you understand by that? If you give low dose, the T half is very low. T half is very less if you give a low dose unfractionated heparin, because all of them will go and bind to endothelium. But if you give higher dose, the endothelium is already saturated. With heparin. Now the T half will increase. Okay. So at low dose, the T half is low. At higher dose, the T half is more, and it will show a dose-dependent clearance because of the binding to endothelium. Okay. Binding to endothelium, it will show a dose-dependent clearance, and binding to plasma protein will cause unpredictable activity or unpredictable response. Excretion is extrarenal. Excretion is extrarenal to binding to macrophages and internalization and proteolysis. And then proteolysis inside the macrophage. So important thing is excretion is extrarenal. That means it is safe in renal failure. So probably this is one indication. This is one of the very important indication. In acute medicine, you will find patients with renal failure, with acute kidney injury, and in those patients, if you want to give anticoagulation, it's always preferred. Unfractionated heparin is always preferred over lower molecular weight heparin or Fondaparinux. Okay, because the excretion is extrarenal, unlike LMWH. Okay, and excretion is happening through the macrophages. Okay, next important point is what is the T half. Now T half is around 30 to 60 minutes. If you give IV, T half is around 30 to 60 minutes. That's why it is always you have to give continuous IV infusion. Now this is also important for us to understand, because the T half is very low, because very less. T half is very less. In those cases where we are planning surgery. Or any kind of intervention, again, unfractionated heparin is always preferred. Okay, so these 2 points are important to remember. In renal failure, we always prefer unfractionated heparin, and in cases where we are planning surgery, for example, a case of cerebral venous thrombosis, and we have to start anticoagulation, but we are expecting that the thrombosis and the related edema or hemorrhage is so much that the patient may need a decompression craniectomy. In those cases, we have to start with unfractionated heparin, because at any point of time, if you want to go for surgery, you can just stop the unfractionated heparin, and after 6 to 12 hours, you can, after 4 to 6 hours, you can go for surgery. Okay, so these are the 2 very clinically important points about unfractionated heparin. First thing is excretion is extrarenal, and second point is TF is very low. That's why you can give to the patients who are planned for surgery, or you are thinking that they may be posted for surgery or some kind of intervention. Okay. Now the next thing is regarding binding to plasma protein. What are the other plasma proteins that this heparin can bind apart from antithrombin? So they can bind to the acute phase reactants. Like albumin. Albumin is a negative acute phase reactant, like fibrinogen, which is a positive acute phase reactant. So it can bind to albumin, it can bind to fibrinogen, it can bind to high molecular weight multimers of von Willebrand factor, high molecular weight multimers of von Willebrand factor. And very important point, it can bind to platelet factor 4. It can bind to platelet factor 4. The binding to this platelet factor 4 can cause increased activity. The platelet factor 4 is released from the platelet, and because these heparins have a like very high affinity for this platelet factor 4, this leads to decreased activity of heparin near platelet rich thrombus. Near platelet rich thrombus. And also we'll be studying about heparin induced thrombocytopenia. Here also it is important that this binding of platelet factor 4 to heparin actually initiates the process of heparin induced thrombocytopenia. So these are two clinically important points that you have to remember. Because of higher affinity for binding into this platelet factor 4, it will lead to decreased activity of heparin near the platelet rich thrombus, and there is also a risk of heparin induced thrombocytopenia. Okay, and because they bind to these acute phase reactants, and you must be knowing that the level of acute phase reactants, they will vary person to person. They will vary according to the situation, according to the stress level, according to the inflammation that is happening inside the body. That's why the amount of acute phase reactants are always variable, and that's how it can cause variable serum level of this heparin, and that will lead to a very unpredictable response. This is the reason for unpredictable response associated with heparin, unfractionated heparin. Next thing is, how will you monitor this anticoagulant effect of unfractionated heparin? So monitoring is done by via APTT. Monitoring is done by APTT. APTT is used for monitoring the effect, monitoring the activity of the intrinsic pathway. Heparin predominantly affect the intrinsic pathway, so that's why we use APTT. And remember, for therapeutic effect, we need a APTT of 2 to 3 times. Okay, so APTT should be prolonged for around 2 to 3 times to have so that we can tell that our heparin is working, our unfractionated heparin is working, if the APTT is get prolonged 2 to 3 times, and that is the therapeutic effect that we want to achieve. Okay, we want to achieve for a given dose. But apart from that, you can also use factor 10A. Which is a little bit more specific than the APTT. Okay. Now, when do you call something as heparin resistant? You call it heparin resistant. Remember, around 25% of venous thromboembolic patients, they will require unfractionated heparin of more than 3,500 units per day to reach therapeutic APTT levels. Okay, so this is known as heparin resistant. So in any case of venous thromboembolism, if you are using more than 3,500 units per day of heparin to achieve the therapeutic level of APTT, that is 2 to 3 times of normal, that is known as heparin resistant. So how we use heparin? So heparin, we have to start as a continuous IV infusion. Then you have to send your APTT levels at regular intervals, and you have to check whether the APTT is getting prolonged or not. If it is not getting prolonged, then you have to increase the infusion rate, and like that you have to monitor till you are getting APTT level of 2 to 3 times normal. Okay. So in any patient, if you are using more than 3,500 units of unfractionated heparin per day to achieve the therapeutic APTT level of 2 to 3 times normal, that is known as heparin resistance. Okay, and it is seen in 25% cases of venous thromboembolism. In such cases, it is better to monitor via factor 10A. Now coming to the dosing, if you are using prophylaxis, then you have to use 5,000 units sub-Q, BD or TDS. If you are using as therapeutic dose, which is very less commonly used, unfractionated heparins are very less commonly used therapeutically because we have better alternatives in the form of low molecular weight heparin or Fondaparinux. But if you want to use heparin, as I have already told, in case of renal failure, we tend to prefer unfractionated heparin, and in cases where you are planning for surgery, you can use unfractionated heparin. So therapeutic dose for acute coronary syndrome is around 5,000 units per kg IV start or IV bolus, followed by 15 units per kg per hour. For venous thromboembolism, it is again 5,000 units per kg or 80 units. Sorry, it is 5,000 unit IV start or 70 unit per kg. 70 unit per kg IV start. In the second case, it is either 5,000 units or 80 unit per kg IV start, followed by 18 units per kg per hour. Okay, so you can give a bolus dose of 5,000 units, followed by, if it is acute coronary syndrome, you give 15 units per kg per hour. If it is a venous thromboembolism, you give 18 units per kg per hour. So this is the dosing. If you are doing your residency, then you must be familiar with all these dosings. Now, what are the limitations of unfractionated heparin? Till now, we have discussed about the pharmacology, and we have already discussed about many points regarding this. What are the limitations of unfractionated heparin? We'll just try to summarize them. Poor bioavailability at low dose. Poor bioavailability at low dose because they bind to endothelium. This I have already discussed. Because they bind to endothelium, they have a poor bioavailability at low doses. Dose dependent clearance, again because of the binding to endothelium and also because of binding to the plasma protein. Variable anticoagulant response because they bind to plasma proteins, and I have told these acute phase reactants will vary. Acute phase reactants will vary according to the level of inflammation that is happening inside the body. So, they will have a variable anticoagulant response, unpredictable response. Okay. And a reduced affinity in the vicinity of platelet-rich thrombus. This is because of binding to platelet factor 4. This I have already discussed. Because they bind to platelet factor 4, which will reduce the activity of heparin at the vicinity of platelet-rich thrombus. Then limited activity against factor 10A incorporated in prothrombinase complex. This prothrombinase complex will have activated platelets. So that's why it will reduce the effect of heparin through the platelet factor 4. And also they have limited activity against thrombin, which is bound to fibrin. They have limited activity against thrombin, which is bound to fibrin, because of their limited access to catch the thrombin. Okay, so these are all the limitations. This we have already discussed. Now coming to the side effects, bleeding is the most common side effect, most common and most important side effect. So what antidote we have? What antidote we have for bleeding? The antidote is protamine sulfate. Protamine sulfate. So this is prepared from salmon sperm. This is prepared from salmon sperm. 1 mg of protamine sulfate is needed to neutralize 100 units of unfractionated heparin. And you have to give it as a slow IV because there is a risk of anaphylactic reaction. I hope this is clear. These are the 4 points about protamine sulfate that you have to remember. Antidote. This is the antidote of choice for unfractionated heparin. It is derived from salmon sperm. 1 mg of protamine sulfate can neutralize 100 units of unfractionated heparin. It has to be given as slow IV. It has to be given slow IV because there is risk of anaphylactic reaction. Now, second most important adverse effect is HIT, heparin-induced thrombocytopenia. It's a very common clinical situation. Now, this is because of an antibody-mediated process that is triggered by antibodies directed against neoantigens on platelet factor 4. Now, because I told platelet factor 4 has a very high affinity for heparin, And because this heparin platelet factor 4 interaction, there will be production of new antigens over platelet factor 4 against which antibodies will be formed. Okay, and they will cause damage of platelet. Now this is a condition where there is thrombocytopenia, but along with thrombocytopenia, we are also having thrombosis. Usually thrombocytopenia is related to bleeding, but this is a condition where thrombocytopenia is related to thrombosis. And this is not the only condition. There are so many other conditions like DIC, like TTP, HUS. There are so many other conditions that we will be discussing later. But for the timing, you remember, it is also a condition where we are having thrombocytopenia, but along with that, we are having thrombosis rather than bleeding. Okay, and this is because of the damage to the platelets and release of the platelet products, which will stimulate the, which will cause thrombogenesis. Okay, so what are the features of heparin-induced thrombocytopenia? The first point is thrombocytopenia itself, and how will you define it? Either the platelet count of less than 1 lakh, or a drop of more than equal to 50%. Second point is, what is the timing? It is around 5 to 14 days. Within 5 to 14 days after starting heparin. Type of heparin, unfractionated heparin has higher propensity to cause hit rather than low molecular weight heparin. Okay, low molecular weight heparin carries a very less risk of this heparin-induced thrombocytopenia. Now coming to the type of patient, it is usually seen in surgical patients more than medical patients. And more common in females than males. Now thrombosis, venous thrombosis is more common than arterial. So arterial and venous, both thrombosis is possible. Venous thrombosis is much more common than arterial thrombosis. So these are the points, features of heparin-induced thrombocytopenia. Now coming to the diagnosis, remember, most of the cases it is a clinical diagnosis. And in many situations in our clinical practice, we don't do any further investigation, rather than we use this temporal correlation and make a clinical diagnosis of heparin-induced thrombocytopenia. But theoretically, you have to remember the most sensitive test is ELISA to identify these antibodies against this platelet factor 4, but the most specific test is serotonin release assay. Coming to the management part, management for the first point is you have to stop unfractionated heparin, of course. Stop unfractionated heparin. Remember, do not transfuse platelets. Okay, it will increase the risk of thrombosis, and also because there are antibodies against this platelet. So even if you transfuse, it will be of no use. It will be waste. Okay, so don't transfuse platelets. Now you have to give direct thrombin inhibitors. Either you give argatroban. We'll be discussing about it. Argatroban or bivaluridine. Sometimes Fondaparinux can also be used, but these are always preferred. What about warfarin? Now warfarin, you should not start upfront. Do not start upfront. Because there is a risk of skin necrosis, warfarin-induced skin necrosis. I'll be discussing the mechanism behind this in under warfarin, so I'm not going to discuss here. So do not start warfarin upfront. Always start with direct thrombin inhibitors, argatroban or bivaluridine, and then gradually, once the platelet count normalizes, that is more than 1 lakh, then you can gradually start with low dose warfarin, and continue. I hope you all must be knowing that whenever you want to give anticoagulation for immediate response, we always start with parenteral anticoagulant, that is heparin. We always start with parenteral anticoagulants to have an immediate response, and gradually we switch over whenever you want a prolonged phase of anticoagulation therapy, which is the need in most of the cases, like in case of DVT or in cases of pulmonary embolism. or in cases of cerebral venous thrombosis, all these venous thrombosis cases, we always want to give the anticoagulation for at least minimum 3 months, or in some cases 6 months, or in some cases maybe lifelong therapy. Those things we'll be discussing under the particular disease itself. So what is the basic understanding behind that is, always we start with parenteral anticoagulants, that is heparin, and then we gradually switch over to oral anticoagulants, and the classical example is warfarin. Of course, we have so many direct newer oral anticoagulants also. But this is the concept behind it is, we start with parenteral anticoagulant because we want immediate response. Oral anticoagulants, the classical is warfarin, takes at least 5 days for its action. So that's why we always start with IV anticoagulant and gradually switch over to oral anticoagulant. And the prototype example is warfarin. Of course, we have some newer oral anticoagulants who doesn't need this kind of bridging therapy. This is known as bridging. And this kind of bridging therapy is not needed for some of the newer oral anticoagulants that we will be discussing. But for classical warfarin, we definitely need bridging. That's why we always start with IV therapy and then we switch over to oral therapy, and to achieve the therapeutic INR level. Okay, to achieve the adequate therapeutic anticoagulation level. So that is the case here. In case of heparin-induced thrombocytopenia, even if you have a therapeutic anticoagulation level, you should not start with warfarin, because there is a risk of skin necrosis, and the mechanism behind that I will be discussing later. Okay, so in case of heparin-induced thrombocytopenia, start with direct thrombin inhibitor, that is argatroban and bifenthrin. Sometimes you can use Fondaparinux also. And once the heat is settled, once the platelet count recovers, you can gradually start with low dose heparin. Okay, low dose heparin. In acute setting, never start with heparin. So I must tell that these things may sound complicated if you are not exposed to clinics. If you are already a resident or you are already managing these cases, I don't think I need so much of explanation, because you must be very familiar with these concepts. But for them who are in final year or who are in intensive, who have not started managing cases on their own, and they are not familiar with how the anticoagulation is being done, this might seem difficult, but if you read it again and again, I think you will be able to understand. This is a important concept that is given in newer edition of Harrison. It was not there in the previous edition. You all must be familiar with this. This is known as vaccine-induced thrombocytopenia, vaccine-induced thrombocytopenia, and thrombosis. Remember this HIT also. This HIT also sometimes written as HITT. That is heparin-induced thrombocytopenia and thrombosis. Similarly, this is also vaccine-induced thrombocytopenia and thrombosis. This is associated with adenovirus based COVID-19 vaccine. With CVT, cerebral venous thrombosis, or splanchnic venous thrombosis, or maybe DVT and pulmonary embolism. For the initial case reports, most of the cases presented with cerebral venous thrombosis. This is also antibody mediated, antibody against the platelet factor 4. But here the treatment is, you have to use either IVIG or plasmapheresis or steroids. To reduce the effect of these antibodies, we can use all this. Okay, so this is the newer concept. Of course, you must be familiar with this bit because of the COVID pandemic, but this is the newer addition in the recent edition of the Harrison. Now, so next side effects. So the first we have discussed about the bleeding, then we discussed about the heparin-induced thrombocytopenia, bar thrombosis. Then now we are coming to the last two adverse effects, that is osteoporosis and elevated levels of transaminase. Remember, this is a reversible condition. Once you stop heparin, unfortunate heparin, then it will be normalized. Osteoporosis, the mechanism behind osteoporosis is it is causes inhibition of osteoblast and activation of osteoclasts. So it causes both decrease in production and increase in absorption of the bone, so that's how it causes osteoporosis. And anytime we use unfractionated heparin for more than 1 month, leads to significant risk of osteoporosis. Significant risk of osteoporosis. These are the 4 side effects, adverse effects of unfractionated heparin. So the next thing is low molecular weight heparin. I have already discussed the mechanism behind low molecular weight heparin. This has from the name itself, you can understand it has a lower molecular weight because it has 17. It has 17 polysaccharides. It has 17 polysaccharides, and the mean molecular weight is around 5,000 Daltons. Okay. Now, what are the advantages of low molecular weight heparin over unfractionated heparin? So, what are the advantages over unfractionated heparin? Many of these concepts we have already discussed. Now, we'll be just summarizing those things. It has a better bioavailability and longer T-half after subcutaneous injection because it doesn't bind to endothelium. Doesn't bind to endothelium and other plasma proteins. Much it doesn't bind to endothelium and other plasma proteins. That's why they have a better bioavailability and they have a dose independent clearance. They have a predictable anticoagulant response because they don't bind to plasma proteins. That's why they have a very good predictable anticoagulant response. And what is the consequence of this? This is the mechanism, and what is the consequence? We can use. We don't need any monitoring. We don't need monitoring. In case of unfractionated heparin, we use monitoring because the response is unpredictable. So that's why we have to look for the PTT and change the dosing accordingly. But here in this case, because the response is predictable, we did not do the monitoring. Because they have better bioavailability and longer T-half, we can use them as like OD or maximum BD dose. OD or BD dose we can use. They have lower risk of hit. I have already told they have lower risk of hit, and also they have lower risk of osteoporosis. Yeah, so it can be used for longer run. So longer use is possible because they have a lower risk of osteoporosis. Okay, and because they have a lower risk of hit, it can be used. It can be preferred in patients who have thrombocytopenia, who have already thrombocytopenia. LMW is preferred over unfractionated heparin. Okay. Now coming to the mechanism of action, this I have already discussed because they have 17 polysaccharides. They will have factor 10A activity, but they will have reduced factor 2A activity. And the ratio I told, anti-factor 2A to anti-factor 10A activity is 2:1 to 4:1. Okay, so the activity is 2:1 to 4:1. Now coming to other pharmacological concepts, it is given subcutaneously. And the bioavailability with subcutaneous injection itself is 90%. Okay, but it can also be used IV, but always subcutaneous route is preferred because the bioavailability is very good. Its T-half is around 4 hours, and it has a renal excretion. It has renal excretion. Yes, renal excretion. So this is important. That's why I told unfractionated heparins are always safer in patients with renal failure, and low molecular weight heparins are not preferred because they are being excreted renally. Okay, so only 2 conditions I told where we usually prefer unfractionated heparin. That is, one is renal failure, and second one is if you are planning for surgery. Told that low molecular weight heparins, they have a predictable response, and usually they do not need any kind of monitoring. But if the patient is having mild renal failure, and if still you want to give low molecular weight heparin, then you have to do monitoring and adjust the dose. And the other one is obesity. In obesity also the response is unpredictable. So these are the 2 conditions where we want to do monitoring. And the monitoring is done by anti-factor 10A level and not by APT. It's done by anti-factor 10A level. So therapeutic effect ranges from, if you want to remember, you can remember, otherwise you can forget. It's not very important. So it is 0.5 to 1.2 units per ml, 3 to 4 hours after drug. After the last dose of the drug. Anyway, this is not important. This is important. Just remember, anti-factor 10 activity is measured for monitoring. Now, what are the side effects? I told 4 side effects for unfractionated heparin: bleeding, heparin-induced thrombocytopenia and thrombosis, osteoporosis, and increased transaminases, increased liver enzymes. For low molecular weight heparin, the risk of bleeding is there. Of course, the risk of bleeding is there for low molecular weight heparin. But one more point is here, protamine sulfate is not very effective. Protamine sulfate is partially effective. Remember, it is partially effective. You don't have a proper antidote for low molecular weight heparin. Risk of heparin-induced thrombocytopenia is very low. Risk of osteoporosis is very low. There is no risk of transaminases. So only important adverse effect is bleeding. Now coming to the Fondaparinux, this is only the pentasaccharide sequence. I have already shown in the image of mechanism of action. It's only the pentasaccharide sequence. That's why it has only factor 10A activity, factor 10A, anti-factor 10A activity. Now this is taken from Harrison, which is showing some of the differences, and these points I have already discussed. So it will be very easy. The number of polysaccharide units here is only 5 because it is only the pentasaccharide unit. Low molecular weight heparin, it is usually 15 to 17. Anti-factor 10A activity it has, but no activity against factor 2 or thrombin. Bioavailability after sub-Q injection for low molecular weight heparin, I told you it is 90%. For Fondaparinux, it is 100%. Plasma half-life is 4 hours here, I have already told, and this is important. For Fondaparinux, it is around 17 hours, so it is given as OD dose. Renal excretion is there for both, so that's why only unfractionated heparin is safe in renal failure. Induces tissue factor pathway inhibitor. This point is not important, but remember, Fondaparinux does not induce, low molecular weight induces. Neutralization by protamine sulfate. I told it protamine sulfate partially neutralizes low molecular weight heparin, but no effect on Fondaparinux. Now coming to the dosing for venous thromboembolism. For prophylaxis, we use 2.5 mg OD. For therapeutic in established case of venous thromboembolism, the dose is 7.5 mg OD. But if the weight is less than 50 kg, we give 5 mg OD. If it is more than 100 kg, we give 10 mg OD. For acute coronary syndrome, it is 2.5 mg OD. For acute coronary syndrome, it is 2.5 mg OD. Side effect is again only side effect is bleeding. It doesn't have any. It doesn't cause heparin-induced thrombocytopenia or osteoporosis and all. So only side effect is bleeding, and here protamine sulfate is not at all effective. It is not effective. So you can give recombinant factor 7. Recombinant factor 7A can be given, but protamine sulfate is not effective. Okay. Now coming to the last part, that is the parenteral direct thrombin inhibitors. So these includes these drugs: lepirudin, desirodin, vivalirudin, argatroban. Among these, remember, lepirudin and desirodin are the initial ones to be designed, but they are not used now. Because we have better alternatives in the form of vivalirudin and argatroban. Argatroban is preferred drug in cases of approved for heparin-induced thrombocytopenia. Vivalirudin is approved as an alternative to heparin in patients undergoing ACI, percutaneous coronary intervention, especially in cases of heparin-induced thrombocytopenia. So in a nutshell, you can remember that if the patient is planned for percutaneous coronary intervention, but but the patient has already developed heparin-induced thrombocytopenia. In those cases, instead of heparin, bivalirudin is preferred. Okay, bivalirudin is approved for that condition. In otherwise heparin-induced thrombocytopenia case, it is the argatroban that is approved. Okay. Molecular mass site of interaction is thrombin. These points I'll not tell. You can just read from the book. It's not very important. What you can remember is renal clearance. Remember, bivalirudin is not cleared by liver or kidney. It's not cleared by liver or kidney, similar to unfractionated heparin. And remember, this lepidolin and decirodin, they are safe in hepatic metabolism. That means they are not cleared by liver, and they have renal clearance. Exactly opposite for argatroban. Argatroban is cleared by hepatic route, and it doesn't depend on the renal function to be cleared. Okay, so that this is how I remember. How I remembered is L for L. So L for liver. So lepidolin is safe in liver. Lepidolin is safe in liver. Okay, if you remember this much, that is enough. That means lepidolin and decirodin, they do not have hepatic metabolism. They have renal metabolism or renal excretion. Exactly opposite for argatroban. Argatroban is cleared through liver and doesn't depend on the kidney function. And bivalirudin, which is in the middle, it doesn't depend on liver or kidney to be cleared. Plasma half-life is important. In minutes for lepidolin and bivalirudin, it is around 60 minutes. If you give IV, it's around 120 to 180 minutes if you give sub-Q. But anyway, we are not using this. So what we have to remember is for bivalirudin, it is around 25 minutes, and argatroban, it is around 25 minutes. So one thing you can remember, whichever drug has this kind of half-life, that is in minutes. If the half-life is in minutes, that means we have to give all these drugs as continuous IV infusion for any kind of effect. Okay, so these drugs are given as continuous IV infusion. These drugs are given as continuous IV infusion. So argatroban has to be given as continuous IV infusion. Continuous IV infusion. And you have to be very cautious. So avoid in cases of hepatic dysfunction. Avoid in cases of hepatic dysfunction. And I told it is approved for heparin-induced thrombocytopenia. And one of the very important point you have to remember is this argatroban somehow it also increases INR. It increases INR. So what important effect it will have if it is causing increase in INR? So it will cause a very potentially difficult scenario, clinically difficult scenario when you are trying to change over from the parenteral anticoagulant to oral anticoagulant. If you know how you do the bridging, I told we start with heparin. Always we start with heparin or parenteral anticoagulant. Then we also give warfarin. We also give warfarin, that is the oral anticoagulant, and we monitor the INR. We monitor the INR. Once the INR comes to therapeutic range, that is around 2 to 3. This coming to this therapeutic range of 2 to 3. By the help of warfarin, it takes around 5 days time. More on this we'll be discussing under the section of oral anticoagulants. Okay, because warfarin inhibits the factor 2, 7, 9, 10. The minimum time it needs is 5 days because of the half-life of those factors. Okay, so to achieve this effect, it needs at least 5 days. And during those 5 days, we want to give IV anticoagulant so that it will have the anticoagulant response. And once we achieve this INR, we discontinue the IV therapy, we discontinue the parenteral anticoagulant therapy, and we continue oral anticoagulants. Now, this is how it happens. And remember, this heparin doesn't have any effect on INR. It doesn't have any effect on INR. So in cases of hit, when we have changed from heparin to argatroban, what will happen? So we have changed from heparin to argatroban. Now we are using argatroban as parenteral anticoagulant, and now we are trying to give warfarin and switch over from parenteral to oral anticoagulant. But now whenever we are monitoring INR, I told that this argatroban will also increase the INR, so it will give a falsely high INR level. So we'll have a difficulty in stopping the IV anticoagulant. Because argatroban is falsely increasing the INR. So instead of these 5 days, this INR may come to the therapeutic level. INR may come to therapeutic level falsely within maybe 1 to 2 days. So if you think that INR has, if you think that INR has become INR has come to therapeutic range and you stop the ergotamine, but in reality, warfarin has not produced that much effect to cause a therapeutic INR. Then that will lead to a disastrous scenario. So that's why this increase in INR by ergotamine causes a very like a difficult situation clinically. Now, how to overcome this situation? Instead of INR, you can do factor 10A monitoring. You can do factor 10A monitoring. And if you want to do INR, at least the sample has to be taken. The sample has to be taken after 3 hours of last dose. 3 hours of last dose of ergotamine. Evaluatin, I told it is not cleared by kidney or by liver. It is this peptidase enzyme actually cleave this evaluated and it is partially excreted by kidney. Only partially, okay. This evaluatin are higher dose that is used during the cardiac surgery. We have to monitor via activated clotting time. And if you are using lower dose, you can monitor through APTT. So this is monitoring. If you are using higher dose, use activated clotting time. If you are using lower dose, use APTT. So that's all about parenteral anticoagulants. I know it's a bit lengthy and it is tough, but that's how it is. The purpose of making these videos, they're all based on the Harrison's textbook of internal medicine. So my purpose is it will make your life a little bit easier while you are reading the textbook. Okay, so that's what I want whoever is listening to this video. After listening to this video, definitely go back to Harrison and read the textbook. And I hope it will make your life easy while reading the textbook and you can start enjoying the textbook more. Okay. So thank you so much for listening. In the next lecture, we'll be discussing about the oral anticoagulants, and after that, we'll be discussing about the fibrinolytics.